In our previous video, we talked about atherosclerosis. That was that little gruel-like cholesterol plaque in your vessel. And that plaque can grow and start to narrow the vessel. And if there's tissue that your blood vessel has to supply at the end, well, not as much blood will get to it, right? So that tissue is a little bit starved of oxygen, of blood. And if you have atherosclerosis of your coronary vessels, the vessels that supply your heart, then your heart doesn't have enough blood supply, doesn't have enough oxygen. So let's just look at your heart. Your heart, like your blood vessels, is made up of 3 layers. It has the inner endocardium. It has the middle myocardium, which is where the muscles are, judging by the name. And then it has your outer layer, the epicardium. And your coronary artery is the thing that supplies your heart, is on the outside, right? And it will diffuse blood inwards. And so your endocardium is the last to get its blood. It gets the short end of the stick, okay? If you have a little plaque here, then you kind of narrow it. You kind of reduce the amount of blood oxygen getting into your heart, especially your poor endocardium. Okay. If you have a plaque that's over 70% occlusive, if it covers over 70%, that's pretty serious, right? And then you will start to feel that lack of oxygen. You're going to start to have pain, especially if you exercise. If you exercise and increase the demand your heart needs for oxygen, you'll have that pain. We call that stable angina. Stable angina. Pain on exertion. But if you stop exerting, if you're just at rest, the pain goes away. All right, so you know it only comes during exertion. It's stable. And we can test for stable angina. Via the stress test. There are different ways we can do this. We can do the exercise stress test, where we literally put a person on a treadmill, run them on a treadmill, and sure enough, they get that chest pain because they don't have enough oxygen, enough blood to supply their heart. We can do pharmacological stress tests. So if a person doesn't want to run on a treadmill or can't, we can just use a drug, a vasodilator called dipyridamole. You give them that drug and they feel that chest pain. Why do they feel that chest pain? Well, let's just draw some blood vessels out. Okay, let's say this blood vessel has the occlusion. And the organ, the tissue that is supplying, doesn't get enough blood. And so it will know that, and it will vasodilate. Try and get as much blood as possible. It will maximally vasodilate till it can't dilate anymore, right? That's our body's way of compensating for that, and it will try and get as much blood to it as possible. When you give a vasodilator, it will dilate your other vessels. And more blood will go to these vessels. The problem is this vessel can't dilate anymore. And so you just steal blood. You steal blood to these other vessels when you give them a vasodilator. They feel that loss of blood, they get that angina. That is how you do a pharmacological stress test. Okay, so that's what happens when you have 70% occlusion, but that plaque can keep growing. In fact, it can even burst and create a near occlusion. And when you have a near occlusion of the vessel, then you really are starved of oxygen. You can have chest pain even when you're just lying there, when you're not doing anything. We call that unstable angina. All right. Your cells are very starved of oxygen, but they're still alive. Cells are still alive. They just need more oxygen. Okay? Eventually this can progress into full occlusion, and we call that a myocardial infarction. Infarct means lack of blood supply causing tissue death, necrosis. Here, cells are dead. That is the biggest deciding factor. So, all right, cell death is what separates the two. Cell death usually happens after just 30 minutes of not getting enough blood supply. You get cell death. Now we can divide this. There's a less severe form, if there is such a thing. where only your endocardium is affected. All right, so you have occlusion, your blood supply here, but it just can't reach the endocardium. It's just too far. So your endocardium dies. We call it subendocardial. Then you have a really bad type where you have a really bad occlusion for really long. Your entire wall, all 3 layers die. That's called transmural, across the wall. Transmural. You can imagine that's going to be pretty severe. Now, how can we tell them apart? Yeah, we're not going to biopsy this person's heart, right? So we do it through ECG. ECG. And ECG, again, will show the conductance of your heart. And if you have heart damage, it won't conduct the same. Endocardium, anything that affects the endocardium, so that includes this and all our angina states, because that affects our endocardium star for oxygen, will show up as ST depression. Right. So if we draw our regular ECG, we got our P wave, QRS, and our T, right? And this is our S and our T. This will cause ST depression. So it looks like this. Look like that. How about transmural? This is the opposite. It causes ST elevation. So your ST segment will elevate. So now it looks like this. Now it looks like this. So this segment will elevate. Now it looks like this. Anytime you see ST elevation, it's only 2 things. It's a transmural insult or problem, or something wrong with the pericardium. We'll talk about the pericardium in the next video. But you see, ST elevation is not much it could be. Transmural insult or something wrong with the pericardium. All right, to illustrate the point, there's something called Prinzmetal angina. Prinzmetal. This is a vasospasm where your vessel is completely spasm, completely closed, and your entire wall feels that. Well, that'd be ST depression or ST elevation. ST elevation, right? That's exactly what you see. How do you treat it? Calcium channel blockers. We said that dilates your vessels, releases, relaxes, stops that spasm. Okay. That is the ECG changes you need to know. Now let's say someone comes in, chest pain, you do an ECG, you see ST depression. ST depression. So you know something's wrong with the endocardium. How do you know whether it's unstable angina or how do you know it's a myocardial infarction? I mean, both of them have ST depression, but what's the difference between the two? What's the dividing line between the two? It's cell death, right? Cell death. And when cells die, they release a bunch of gunk. They release a bunch of enzymes they held inside their body. They release things like troponin. Now, troponin is not sensitive by itself. It's seen in all muscle cells, but certain types of troponin are sensitive to the heart. That's troponin I and T. We usually use I. Okay. And we also throw in another enzyme called creatine kinase. M and B. Sometimes it's called CKMB. Okay. Troponin is our gold standard. Our gold standard, we just draw that. If it's high, we know it's an infarct. So why the heck do we have CKMB? Well, CKMB rises really quickly and then drops really quickly. Drops within 48 hours. Okay, so if someone has heart attack, it's going to rise, and then let's say a couple days later, we're seeing it drop, and then it spikes up again. What happened? They had another heart attack. Because it drops so sharply, if we see it spike up again, we know they had a reinfarct. Reinfarct. That's why CKMB is great for diagnosing reinfarct. Another one that we don't use that is more kind of theoretical, which means is a great board question, is LDH1 and 2. LDH1 is found in the heart, LDH2 is found in the muscle, just a regular muscle, and because we have more of just regular muscle, we have more LDH2, right? That makes sense. But in a heart attack, when you muscle cells die and release all that, then the ratio is flipped. LDH1 becomes more prevalent. We call that the LDH flip. They like to test that. We don't use it in practice, but just keep that in mind. Now, when you have a heart attack, ECG shows all these changes. What actually happens to the heart during this process? Let's just see what happens and all the complications that come with it. Within the first 24 hours, it's the most deadly. This is where most people die. When your heart cells are damaged, they don't conduct as they should. You get arrhythmias. This is the most common cause of death. Most common cause of death. You gotta know. I'll put a star so you don't forget. If they die within 1 hour, we call that sudden coronary death. Okay, and it's often due to arrhythmia. What's the most dangerous arrhythmia? VFib. Go into VFib, die right away. Their heart can't pump, so they can also go into shock, or they develop heart failure. Microscopically, you're going to see the neutrophils start to come in. You're going to see coagulation necrosis from the cell death. You're going to see perfusion re-injury. Sometimes we can break that clot down and blood goes back into your heart, which just sounds good, right? And it is good, but there's also some side effects. You can have increased calcium going in, which causes contraction. And because your cells are dead, they can't relax. So he's contracting, they can't relax. You see this as contraction bands on biopsy. Oxygen goes in, and that causes free radical damage. So this is all perfusion injury that can happen within the first day. Within the first couple days, 1 to 3, the most common cause is still going to be arrhythmia. But you'll start to see something else. You'll start to see fibrinous pericarditis. Your heart is surrounded by a sac called your pericardium. And with all this damage and inflammation going on, you can have fibrinous pericarditis. How do they like to ask it? A couple days after myocardial infarction, suddenly they develop another chest pain. That's worse on inspiration. You listen to the heart, you hear a friction rub, which is what you see in pericarditis. So friction rub. That's how they like to ask it. Within a couple weeks, your macrophages come in. You start making granulation scar tissue, and you start to remodel your heart. This is a very crucial time, but your heart is very soft. The wall is very soft. It can rupture, it can burst, it can open at any time. So, right, soft wall. It can burst and cause bleeding into your pericardial space. We call that cardiac tamponade. Your papillary muscles, those are the muscles we said that hold your valves, can rupture. Papillary rupture. Your valves are no longer able to close. That causes a murmur. A murmur. Your interventricular septum can rupture. That causes another murmur. So you have the septum dividing your ventricles rupturing. You have a hole in between your septum. Isn't that a VSD, ventricular septal defect? So you can have another murmur. We haven't talked about murmurs yet, but we're going to talk about them soon, okay? And then lastly, you can have a little tear in the wall and blood can collect and look kind of like an aneurysm. We call that a pseudoaneurysm. We call it pseudoaneurysm because normally aneurysms don't have ripped walls, but it looks enough like an aneurysm that looks, we call it a pseudoaneurysm. And this aneurysm can pop, blood leaves, there's a hole in your heart. I mean, high mortality rate. Shouldn't have to say that, but that is another complication. You can just basically have a free wall rupture. Free wall rupture. Okay? How do they like to ask all this? We haven't talked about many of those pathologies, so we're kind of jumping the gun, but I'll just say it here. Tamponade, blood leaks, traps your heart. You'll listen to the heart. You'll hear very faint heart sounds. You'll have hypotension because the blood's not pumping out, it's pumping into your pericardial sac. You'll have distended veins. You see that? They have a tamponade. The murmurs, about a week after MI, you listen, you have a new murmur, something wrong with the papillary muscle or the interventricular septum is ruptured. Pseudoaneurysm, there's no way they can ask it. They have to show you a picture, show you a little aneurysm. 3 to 14 days after MI, pseudoaneurysms. If they show you hemorrhage, a hole in the heart, it's a free wall rupture. Okay? That's how they like to ask it. Now, after 14 days, we'll just say 2+ weeks and more, you have our scar tissue. And scar tissue doesn't contract, so you have a lasting deficit in your heart due to that myocardial infarction. Your body can get exposed to all the antigens that are held neatly in your heart, and you can develop something called autoimmune pericarditis, aka Dressler syndrome. So, all right, autoimmune pericarditis. We already talked about a pericarditis. We talked about it right here. What's the difference? Well, the difference is this happens 2+ weeks. If they ask you of a pericarditis that happens weeks after a myocardial infarct, it's an autoimmune pericarditis. We call it Dressler syndrome. We call it Dressler syndrome. And lastly, that scar tissue can bulge out. Blood can collect on it. And that blood doesn't get pumped well. You create a little clot. We call that a marrow thrombus. And this outbulging we call a true aneurysm. True aneurysm with a marrow thrombus. Okay, I think we've talked a ton about the complications and what happens during a myocardial infarction, but let's say someone comes in with an MI, how do you treat them? You're on the floor, they're all looking at you, they want you to know what is the next step. How do you treat them? Well, we can try and relieve the pain with things like oxygen, things like morphine, even though it's not well studied, things like beta blockers. You reduce the myocardial demand, the amount of oxygen that your heart needs. You kind of reduce that stress, right? If your heart doesn't need to pump as hard, doesn't need to pump as fast, you can reduce that stress. Another way you can reduce the stress is with nitroglycerin. This is NO. That seems to really like your veins more. Your veins more. So it dilates your vessels, helps blood supply to your heart, and also reduces the oxygen demand of your heart, reduces the amount of stress. Because when your veins dilate, then blood pools there, reduces the amount of blood that goes back to your heart, reduces the amount that it has to pump out. So it can reduce that stress, and that reduces pain. You can break down the clot. You can do TPA if under 6 hours. You can go in the vessel and stent it. Percutaneous coronary intervention. And then you manage it after the fact with things like long-term antiplatelets to stop further clots. Give them statins for the hyperlipidemia. You can give them ACE and ARBs. Again, that works on the RAS pathway, and that reduces the preload, reduces the amount of fluid, and makes your heart have to work less. And after a heart attack, I mean, you don't want to stress it anymore. And this helps heart remodeling. Make sure it doesn't have to work as hard, have to remodel as hard after that insult. I saw a chart in first aid that kind of compared beta blockers and nitroglycerin. I just want to go over that chart really quickly. And that way you kind of understand what they're talking about. So nitroglycerin, beta blockers. And I think they had different categories. They had end-diastolic volume, they had ejection time, they had a heart rate, and they had contractility. End-diastolic volume and nitroglycerin, your veins dilate, your blood will pool. You'll have less blood going to your heart, so your end-diastolic volume will decrease. Ejection time. If you have less blood in your heart, you can eject it quicker, so ejection time will decrease. Heart rate, when you have less blood in your heart and you pump less blood out, your blood pressure kind of drops, right? Your blood pressure kind of drops. And when your blood pressure drops, then your baroreceptors will sense that, will freak out, and will try and increase your heart rate. We call that reflex tachycardia. Reflex tachycardia. And so a side effect of nitroglycerin is hypotension. You can get too hypotensive. In fact, if any man comes in with an MI, one of the questions you ask them is, do you take things like Viagra, Cialis? Because that also causes hypotension. That's a nitrate that causes hypotension. And if you give them two together, then they can have too much hypotension and die. All right, so if you ever see one of those Cialis commercials, at the end, they say, don't take nitroglycerin if you're taking this, blah, blah, blah. That's why. Contractility has nothing to do with contractility, so that stays the same. Okay. Beta blockers. Beta blockers, we said sympathetic beta activity increases your heart rate, increases your contractility. Well, if you give them a beta blocker, decreases your heart rate, decreases contractility. By decreasing contractility, you don't eject enough, you don't eject as much blood out, volume rises. If you have more volume, it takes longer for the ejection time. Ejection time rises. Heart rate, beta blockers reduce that heart rate, goes down. Contractility, we said beta sympathetic activity increases it. If you give them a beta blocker, decreases it, goes down. That is myocardial infarction, that is angina, that's all the pharmacology. Hope you enjoyed the video. Thanks.